Hello, good morning. I'm Ashok Rokade, consultant rhinologist and anterior surgeon from Winchester and the University Hospital Southampton, UK. I welcome colleagues from around the world on behalf of organizing team to this inaugural Winter Global Rhinology Endoscopic Sinus and Anterior Surgery Webathon. Global Rhinology Network is a registered non-profit organization with a mission to foster surgical education in rhinology and skull-base surgery. We have successfully hosted annual multi-center live surgical webcast, The Lioness, since 2014 in collaboration with Lion Foundation. Thousands of surgeons from all corners of the world have benefited from it. More than 2,000 surgeons from 110 countries have registered for GRACE 2020. We will have hugely informative and engaging sessions presented by eminent rhinologists and skull-base surgeons from around the world. GRACE 2020 is hosted at the Global Telemedicine Studio of Professor Wilco Groneman in Utrecht in Netherlands. It is supported by Medtronic and Karl Storz. Thank you.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients with technology customized to your unique clinical and facility needs? Introducing Stealth Station Flex ENT Navigation System, a customizable system from Medtronic ENT, a market leader in image-guided surgery technology, featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options, with flexibility in hardware design and optional software functionality. Get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
Okay, now Mr. Sean Carrie. Sean.
Hi. You, Christos.
Welcome. Now to introduce, I think everyone knows Sean Carrie. He was the president of the British Rhinology Society and the co-chair of the PRS in London, I think a couple of years ago. And of course, he has a very long presence in rhinology in the UK. He was, I think, one of the first. No, I think he was one of the first ENTs to do a pituitary surgery in the UK. He certainly was when I met him more than 10 years ago in a course, I think, in the States. And but now he will go the other way. So he will not be talking about skull-base surgery and pituitary, but he'll be talking us about office-based endoscopic sinus surgery. Sean, the microphone is to you. Thank you.
That's great. Thanks very much, Christos, and thank you for that introduction. And yeah, thank you for asking me to talk about local anaesthetic procedures, local anaesthetic endonasal procedures. And I think this is really topical at the moment. I mean, we're in the middle of a pandemic. We're certainly finding in the UK that in rhinology in many parts of the country that cases are being cancelled, that theatre are being used for alternative cases, and if anything, there's an enormous backlog of rhinological cases developing. That once we get through the pandemic, once things are a bit more settled, we're going to have a lot of cases that we end up having to operate on, and that's kind of how I want to frame my talk today. I'll give you my disclosures. You can see them there. The most relevant one is that Medtronic were involved in helping us develop our endoscopic local anaesthetic service in Newcastle. So the sort of cases that we might want to consider doing under local anaesthetic are clearly not something like this. I mean, here is a complex frontal sinus problem in a patient who has a dehiscent anterior table, swelling of the subcutaneous soft tissues, and this really isn't the sort of case that we would initially sort of consider for a local anaesthetic, but something like this might be. So here we have a patient who's got nasal polyposis, has got what you might call sort of central compartment, allergic type nasal polyposis with relatively healthy sinuses, healthy mucosa, straight nasal septum. And I sort of looked at these cases over the years and thought, you know, why are we taking these patients to an operating theatre to remove their polyps? Is it not something we can do as an alternative? And that's what I'm going to sort of talk about today. Ambulatory nasal surgery or office or in-clinic nasal surgery has got a long history in North America, where it's been popularized over many years. But I think over the past 10 to 20 years, it's become increasingly popular, largely on the back of balloon sinuplasty. But certainly if you look at Medicare hospital episodes and billing data, between 2012 and 2016, I had a look at that data, and you can see that actually ethmoidectomy and septoplasty procedures have increased by about 300% in office compared to what had been done in the early part of the century. But this sort of office-based surgery hasn't really taken off to any significant extent in the rest of the world. And the things that are kind of driving it for me, and certainly in the UK, have been some patient demand. Patients are actually asking, can they have things done under a local anaesthetic? Do they have to have a general anaesthetic? And we know in urology and cardiology, really complex procedures are now performed in an ambulatory setting. So it's something we ought to be giving some consideration to. In a healthcare system like our own, and like many other healthcare systems around the world, we need to be looking at providing good value care, so the same sort of quality of care that we provide at the present, but at significantly improved savings. And I think I can demonstrate to you that this is a cost-saving initiative. And finally, from our perspective, big problem in the UK is with waiting times, and I think we can address those two in this respect. You'll be very familiar with local anaesthetic cases in your own practice. There's very good evidence for local anaesthetic manipulation of nasal fractures. Manuel in his previous talk was talking about DCRs, and of course there's a long history of performing DCR surgery under local anaesthesia. Balloon sinuplasty, as I alluded to. Nasal polypectomy, traditionally in most centres, has been something that's been performed under local anaesthetic in patients who are perhaps not fit for surgery, but I think that really provides a strong argument that we should be providing in patients who are fit for surgery and therefore fit for local anaesthetic. And there are clusters of centres around the place which are doing turbinate surgery under local anaesthetic. So there are two types of models that you can consider. There's the in-office local anaesthetic, and there's the in-office local anaesthetic with sedation, or perhaps better cited in an ambulatory operating theatre, really, because sedation brings with it its own issues. You need to have a sedation specialist, you need to have the appropriate resuscitation equipment above and beyond which you need with local anaesthetic. and it just makes the whole thing more complicated, actually, if you're using sedation. It's more costly and more time consuming for the patient. So I'm not going to talk about sedation. I'm going to talk about really a system that's based on what the dentist provides. So when you go to the dentist, you don't get changed out of your clothes. You don't expect to have a general anaesthetic. You're in, you're out, and you carry on with the rest of your day. And that's really what we're trying to introduce in rhinology. We can use surface anaesthesia. You can use topical decongestion, such as Lignospan. We favour using cocaine mixed with adrenaline, and I'll come on to that as well. But if you've got concerns about that, you can look at alternative anaesthetic agents such as pseudoephedrine. You can, in addition to that, you can add in infiltration, either local infiltration or some sort of nerve blocks. We tend to use local anaesthetic infiltration in specific sites within the nose, so we'll use it at the root of the middle turbinate. We'll address specific areas on the septum which might require it. But we can also put some local anaesthetic around the nasal vestibule, because what can be a little bit uncomfortable is that sort of fulcrum effect, or the lever effect of instruments and telescope passing into the nasal passages. We don't use nerve blocks. Some centres do talk about using nerve blocks, either blocking the maxillary nerve by infiltrating in through the greater palatine foramen, just medial to that third molar, and injecting a couple of mils in there, or alternatively endonasally in the region of the sphenopalatine foramen to get the sphenopalatine ganglion. But it's not a sort of system that we're necessarily that familiar with using an ENT. And the anaesthesia is pretty variable, actually. It can be effective in the lower part of the nose, and perhaps in the posterior part of the nose it may be of some use, but it doesn't really take out the ethmoid mucosa very, very well, and that's the area that we're particularly concerned about. So the sort of cases that you might want to consider if you were starting a service: septal buttons, dividing adhesions. But as you become more experienced, you can start to consider nasal polyp removal, revision sinus surgery, turbinate surgery, and of course removal of, or at least biopsy of lesions in the nose which don't appear to be sort of simple polyposis. The question that people usually ask is, what is the ideal patient? You know, who is this appropriate for? And really there's no hard and fast answer to this, but you clearly want a patient, when you're assessing them, that's going to be able to tolerate nasal endoscopy. You can't, somebody who recoils as soon as you come anywhere near them with a telescope is clearly not the sort of patient that's going to be a candidate for this. And you have to understand what you're going to be performing here. So you're going to be asking them to lie down semi-recumbent on a bed. You're going to be doing it under local anaesthesia. They're going to have to be in that position for about 30 to 45 minutes. So you have to take them through and inform them of the procedure. There are some contraindications. So obviously bleeding issues would be significant contraindications, but also very boggy nasal mucosa or a very twisted nasal septum are going to be things that make you think, well, is this patient appropriate or not so appropriate for imaging? We work up all our patients to have CT imaging if we're performing anything within the paranasal sinuses outside the nasal cavity. And we go through all the consent options that you would expect to go through with patients. So we provide them with a full assessment of both a local and a general anaesthetic procedure. We give them leaflets in terms of specific local anaesthetic cases or general anaesthetic options, and they have a full anaesthetic pre-assessment, whether they're having a local or a general procedure. And we give them some time to go away and have a bit of a think about it, and then they can contact the department with their decision. And as I say, this is the sort of case that you might want to consider starting out with if you're just starting off your practice. If you're more interested in developing your practice, then you may want to consider something a bit more complicated that's a previous surgery in the past, and certainly may be an option for local anaesthetic. You've got to think about how you're going to set up your service. We run ours in an outpatient clinic, and we use outpatient staff. So you've got to train your staff. We perform ours in the morning, and we do 3 or 4 patients in the morning. We have an area where the patients initially wait, then they go into a pre-procedure room where they have the topical anaesthesia applied, and then they move about 20 minutes to half an hour later into an operating room. And we have a sort of gradual process of that sort of movement through in a nice pattern. We use Moffitt solution, so a mixture of cocaine and adrenaline, and we have a checklist, as you would expect under a general anaesthetic. We've developed a local anaesthetic checklist to keep things nice and safe, because we're not using experienced theatre staff, we're using outpatient staff who need things kept nice and simple for them. Patients will tolerate a procedure under local anaesthetic for about 45 minutes to an hour. They won't necessarily go accept anything much longer than that. But the quick recovery for these patients makes it a really attractive option. They're out of procedure, they generally recover about an hour, and then they're home after that. There's not the whole delayed process you'd expect under a general anaesthetic. We go for limited instrumentation. We use a pediatric microdebrider. We use a mixture of endoscopes, and you can see that's about as much as I have on my instrument tray beyond the debrider for these sort of cases. The anaesthetic, it's important if you're doing a local anaesthetic procedure that you have appropriate intravenous access, so they all got a Venflon and IV access. They all are done under an ECG, and they all have pulse oximetry at the time of the procedure. And we use our patties with local anaesthetic and adrenaline, augmented by some lignospan injected as necessary. This is our clinic sort of setup. This was our sort of pre-COVID setup. So you can see this isn't just a standard outpatient clinic. We've got an otoscopic microscope there for doing ear examinations. So we've just commandeered a regular outpatient room. We've got a stack, a debrider, and the 2 main things I would draw to attention here, which are not quite right. The first is that neither myself nor the nurses is wearing a mask or goggles, and that certainly has changed. And one of us should be looking at the patient. We're both too intent on looking at the screen here. And this doesn't suit the surgeon who can't talk to patients. You've got to be able to talk, you've got to be able to keep your patient reassured, you've got to be able to talk to him about what he's been doing in the morning, what he would normally do on a Friday morning. Would he be out tending to his garden or walking his dogs or busy with his yacht? You've got to be able to keep a nice conversation going with him. Because once you do so, you can undertake quite a nice procedure. And here we've got a patient with grade 3 nasal polyposis. This is using a 2.7 millimeter endoscope, hence a rather grainy appearance. But I just wanted to show you that with a pediatric debrider really allows you to perform your surgery under local anaesthetic without any significant difficulties. So here we have removal of polyps, very little bleeding. There's healthy mucosa in this patient. It's pretty straightforward. We can work around septal deflections. You just need to be careful about these little bits of polyp tissue falling into the postnasal space. The patient is awake. There's a risk of aspirating, so we wouldn't take it any further than that before removing that with a pair of forceps rather than let it drip down the back. But you can see you can remove the tissue very straightforwardly, and you can get right into the ethmoids. So we've got the middle turbinate down here on the medially, and we've got the lateral nasal wall laterally. But you can see properly anaesthetized. Taking time to anaesthetize, you can take that right into the ethmoids. And similarly, you can go beyond sort of straightforward polypectomy or revision sinus surgery into dealing with things like mucocoeles. So here we have an anterior ethmoid mucocoele, orbital involvement, but we can see looking at that sagittal CT that's sitting a long way forward, and on our MR, we've got clear demarcation between that mucocoele and the skull base. And again, that's something that you can consider doing under local anaesthetic. So here we have the mucocoele presenting in the region of the axilla of the middle turbinate. We can pass our instrument, use a freer to get into that area, open it up, remove the sort of mucus collection, and then, as you would do with any other mucocoele, you want to widen this out. So using a pair of through-cutting instruments, you can widen that out nicely, and a very nice effect. And there's no reason why you can't do, these anterior presenting mucocoeles any worse than you could under a general anaesthetic. So we don't put nasal packs in our patients. We don't do it under general anaesthesia, so we wouldn't do it under local anaesthesia. As soon as the procedure's finished, the patient's out into the waiting area, adjacent to the operating area. The patient is there for about an hour, has something to drink, has something to eat, has their observations taken, and then we would normally discharge within about an hour, maximum of 2 hours, to get them home. And some of them drive home the same day, and some of them get back to work the same day. And for somebody who's busy in business, that's a really important factor. They don't want to be necessarily have the impact of a general anaesthetic and the sort of the feeling afterwards of being a bit disorientated and not able to carry on with their day. So we published in 2018 our first 80 cases. We have done sort of mixture of cases that you can see there, and out of our 80 so far, we've only had one overnight stay in a patient who had a sort of dribbling epistaxis and needed to stay in. They were packed overnight, taken out the next day and discharged. And if we look at our outcomes, so this is from our first cohort of patients. If we look at discomfort during the procedure, bottom right there, very little discomfort scores, either during the procedure or following the procedure. Minimal headache, minimal epistaxis scores, and no patients reporting problems with visual disturbance, nausea, vomiting, the sort of effects that you would see under general anaesthesia. And our outcome measures in patients having this sort of procedure, so our pre-procedure SNOT scores, a mean of about 55, 15 days post-op 36, and then at 3 months down to 29. So we've got early data. Admittedly, we don't have long-term data, but actually for many patients coming in, having a procedure done, a bit like going to the dentist, is a much more attractive procedure than coming in under a general anaesthetic without necessarily having certainty about long-term outcomes for their particular procedure. Our patients return to work nice and quickly. We operate generally on a Friday for these sort of cases. They have the weekend to recover, and most who are sort of self-employed will be back to work promptly afterwards. The cost savings, I think, are really important here. So if you are in the UK, and clearly it will vary around the globe, but in the UK, 4 hours of theatre time cost about £4,000. So about getting on for about 5,000 to 6,000 euros. So if you're not using that theatre time for relatively straightforward procedures, then you've got that opportunity cost of being able to do more extensive, more complex cases in theatre, whether it's been rhinological or head and neck or what they may be. And I think at the moment this is really important in the pandemic. Theatre time is an absolute priority. But our costing for these patients is significantly reduced as well. So an ambulatory patient, total costs are almost half of a general anaesthetic procedure, and we've got significant time savings for our patients. Local anaesthetic procedures are usually done in about 3 hours, general anaesthetic in around about sort of 6 hours from the patient coming in to being discharged. So I've become a big fan of local anaesthetic procedures in the office-based setting. I think we've demonstrated high levels of patient satisfaction. We've clearly got a shorter patient journey. It's cost-effective, and we've got an opportunity here of stratifying our patients and offering those patients who are suitable for surgery under local anaesthetic the opportunity to be done in office, and therefore freeing up our scarce theatre resources for those patients who really do need it at a time in the pandemic when resources are so scarce. So Christos, I'll leave it at that. Very happy to take any questions or further explanation as you want.
Thank you very much, Sean. That was excellent. And yeah, it's a very welcome. Actually, it's very timely because I think in many countries, people have trouble finding theater time, and especially they are reserving both the anesthetic staff and sometimes even the breathing machines for patients with COVID. So the ability to do a local surgery becomes even more, under local anesthetic, it becomes more important. Let's see, we have some questions from the audience. There are no obvious questions. Let's see in the chat. Office nasal, local anesthesia. A question is, do you perform local anesthesia on one side or both sides when you work unilaterally?
So I would probably just do a unilateral anesthesia. Good question, but if I'm pretty confident the other nostril is normal, I wouldn't anesthetize that. I'd leave it as it is.
Yeah, makes sense. And have you, I mean, that's my question. Have you, in terms of revision draft 3, I've used myself the local anesthetic setting for revising the scar in a draft 3. but to be honest, I haven't had experience with using a drill in that area. Have you had it, or you just take out the soft tissue?
Absolutely. I've no experience of using a drill, but actually, for many of these patients who've had draft 3, the issue is not that there's a significant degree of stenosis. The mucosal disease has recurred to make them symptomatic. So in fact, with a mixture of straight and curved adult debriders, you can do a very quick clearance under local anesthesia with the endogenous adrenaline and endorphins, giving you that really good vasoconstrictive effect that you get with a local anesthetic. And some of these patients, need a sort of regular clearance. It just provides a nice, quick and effective way of doing it.
True. And the truth is, if you have a nice opening and you have the frontal full of polyps, actually it gives you a hand to just get the 60-degree shaver and clean it up, and then, and you avoid the general anesthetic. Any other questions? Let me see. From the audience.
I think, thank you, Sean. No, sorry.
Go ahead.
I was just saying thank you. It was an excellent talk. Really, really helpful, especially in the cost climate in the UK.